ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. If you're a listener of this podcast, chances are you're part of the 11% of Americans employed in healthcare, or you're here to learn more about how our system actually works. Last year, the U.S. spent about $4.9 trillion on healthcare, roughly $14,570 to be exact, per person, and 17.6% of our GDP. Federal actuaries project national spending will reach about $7.7 trillion by 2032, which isn't that far away. And the scale is staggering. 18 of the Fortune 500 are health insurance companies. United Health Group leads the Fortune 500 at number 3, worth roughly $315 billion by market value as of October 2025. In 2024, it hauled in $400.3 billion in revenue and about $14.4 billion in net income. Crazy. CVS Health is in the top 10. The Cigna Group, Elevance Health, and Humana also sit inside the top 50. Meanwhile, watchdogs and lawsuits say the profits are juiced by tactics that limit care. Federal investigators have documented Medicare Advantage plans denying requests that met Medicare's own coverage rules. Nearly 50 million prior authorization requests ran through MA in 2023, with 3.2 million denied. And a class action alleges a United Health subsidiary used an algorithm to cap rehab days, pressuring staff to match the algorithm's prediction rather than patient need. A leader who has spent decades inside the system is today's guest, Karen Ferguson. Karen spent her career turning clinic floor realities into policy conversations. After years leading Arthritis Northwest in Washington State and working in data-driven operations, she retired into her next act, founding Our Stories RX, a nonprofit advocacy group that collects first-person stories from patients, clinicians, and staff. Then organizes these stories to illuminate where rules and incentives derail care. Karen lays out the real workflow of prior authorization in specialty care, eligibility checks, clinical documentation, step edits, quality limits, site of care rules, and the staff it consumes. We discuss how non-medical switching disrupts stable patients and why mid-year benefit changes hit clinics and patients with equal force. Karen argues that reform lands when real stories meet the right policy window, a committee markup, a rulemaking comment period, or a state pharmacy board meeting. Our Stories RX is designed to be ready for those moments when organized evidence are not just anecdotes. We close with the why now. With spending still outpacing the broader economy and consolidation concentrating influence, Karen believes community voices need infrastructure. Our Stories RX is her answer. A place to turn clinic pain points into policy change. Karen Ferguson, welcome to Working Healthcare.
Thank you, Meredith. It's so good to be here and to see you again. Obviously, we're colleagues in the same specialty, rheumatology, which really has been a love of autoimmune diseases for patients and the ability to get the right treatment for our patients that the doctors deem is extremely important for them.
You and I actually met a few years ago, right after COVID. I don't know if it was 2020 or 2021. And we had our National Organization of Rheumatology management meeting in Phoenix, Arizona. And somebody had said, yeah, you're really involved in policy and advocacy. You need to meet Karen Ferguson. And people were shocked that you and I, even though we had attended the same conferences for years, you and I never knew each other.
I remember that. I remember that very distinctly. That exact. We had a lunch together actually.
Yep.
Where I met you.
We had a lunch to try to figure out how to stop these Medicare administrative contractors from essentially limiting care by trying to create a simple, or having us bill for a simple code for a complex biologic or monoclonal antibody, which reimburses similar to a B12 shot when it really is a complex code.
Yeah, when I retired, that's exactly. First of all, when you retire, you get to do the things that really drive your passion. Anyway, you don't really retire; you get to actually work even harder because now you have a passion to do so. And with my 18 years at Arthritis Northwest, really it culminated to the fact that we were taking such good care of our patients. And yet at the same time, and we're a family, obviously, as you know, with very complex diseases. And I used to always say to my doctors, it's not the wonderful medications that we now have available to treat our patients. It's the patients who actually interact with those medications that bring the outcomes that we're trying to desire. And only doctors know that. They know their patients, and they know all of the outlining diseases that they come to Arthritis Northwest for. And so therefore they know the specificness of which biologic is going to be a better outcome for that patient than not. And unfortunately, that is what started this whole passion of mine, is that our doctors became so handcuffed to be able to use the right treatment for the patient, even though it was FDA indicated to do so, that they could not get the outcomes that they desired, and the patient's delay in treatments or the pre-authorizations and all the things that we've talked about, and I'm sure we continually discuss, was at play here to be able to really get to the point of how in the world are we going to be able to treat patients from a physician standpoint, but also from the patient standpoint? How are they going to be able to pay for these medications, which the shenanigans behind that is just gone through the roof and is bankrupting our vulnerable patients to be able to get the treatments that they've paid their insurance companies for.
And you were running a rheumatology practice, and you did a lot of analytics work. I remember you actually speaking at many conferences, sharing all of the data behind it. And then you went into retirement and you founded Our Stories RX. And you also tap dance, which I think is super cool to do during retirement too. But what problem were you really trying to solve where you thought sharing patient stories was the way to do it?
Well, that question is at the heart of exactly what I'm trying to do. So there's two aspects to really getting the right treatment for the patient. One is the clinical data that the physician can document and show exactly what treatments they failed and try to appeal and go to the right means that way, which is becoming even more cumbersome than ever. But the second really is the patient, and the patient's stories are so compelling that that it actually speaks volumes for legislators to be able to hear those stories, because they've heard the other flip side of the story, but yet they're so controlled by the middleman, the PBM of pharmacy benefit managers side of the fence, that doctors' stories don't resonate as well as the patient stories, who oftentimes cannot get treatment, are delayed in treatment, are forced to pay tremendous bills because they can't get their treatments. And it just becomes such a great leverage. Furthermore, the patient actually has the contract with the insurer, not the physician group. And so the patient, because they have a contract, they are so much more empowered to be able to say, look, this is wrong, and absolutely need this treatment to be able to have the outcomes that my doctors deem is important.
So give us a quick roadmap to Our Stories RX. How does a story get collected and structured and turned into policy-ready evidence? Like, what are the hot topics and themes that continue to resurface this year?
That's a great question. And it is a question that we're moving very rapidly toward trying to solve. So the first question that I think I heard you ask is, how do you actually accumulate those stories? Mm-hmm. And patients have a hard time in their own barriers to tell stories, right? They feel that they don't know the navigation of a healthcare system. They don't know their rights to appeal. They don't know that they actually have the voice that can actually change legislation. So the one thing that we're moving toward is to be able to collect these stories with organizations like CSRO, the Coalition of Rheumatology organizations, that actually become on every physician's desktop, for example, that they can actually go, and when they have the data behind it from the physician, which is in the system, and we can do a better job even at gathering that data for the doctors to be able to document the delays and document what's happening to the patient in the delays right in the records, so that they've got the data to support the actual delay itself or the denial itself. But you've got then the patient story side of it, which is the voice and the most compelling part of actually having a patient demonstrate how their quality of care has been diminished, or that they can't afford these medications, so they go without, or they die in some instances because they can't get their hands on the right medications. And these are the kinds of things that collectively together, working together in a coalition aspect, would be unbelievable. But then you would have tremendous amount of ability to actually even specify exactly what is the denial reason. Is it because of pre-authorization? Is it because it's no longer covered by the formulary itself? Is it all different reasons? Formulary, non-medical switching ideas that have put people in dire help.
Are you seeing
use those? So.
Are you seeing different stories surface in 2025 than you saw in 2024? Like, what are those items that seem to be like a continuous theme right now?
Yeah, we just at a panel, for example, we just saw a story from a patient that had Crohn's disease, and she was on medication, and her employer was a self-funded employer. And because it's a self-funded employer, they use different avenues to be able to exclude the specialty medications. And those specialty medications is called alternative funding programs. Those specialty medications then all of a sudden become excluded from a self-funded group, because you can see that a self-funded group has benefit plans that they can actually create. And they, of course, want to take large cost of the specialty medications off their plate. So what they do is they exclude them, rendering the patient uninsured, which is not correct. And then they coerce the patient into applying for patient assistance programs through the manufacturers, which is totally, it's illegal, really, because the patient is insured, and those programs are supposed to be for charity foundations or for people that can't afford medications. And so what's happened now is if that patient cannot get that patient assistance program payment, then they often have to go back and pay the bill. And in this case, this patient had to pay $250,000 for 4 treatments that they had already received. And it was just unbelievable. And so these shenanigans that are happening behind closed doors, and not even physician groups know about these alternative payment models that are coming out that are actually rendering patients uninsured. And it's just criminal that's happening. So there's so many different nuances now to the stories of these patients that were on treatment, we're doing great on treatment, and all of a sudden it's been excluded off of their formulary and they can't get their hands on it. And yet it is FDA approved, and the patient has been on it for an X number of period of time with wonderful results.
When you and I started working together, as I shared earlier, it was a downcoding issue, specifically for Prolia and also for some infusion drugs or more injectable drugs, I'm going to say. So the true code that should be billed is 96401 for those familiar with this. And we were told we needed to downcode to 96372. Besides the financial reimbursement being a huge disparity, about $74 for the 96401 versus $14 or less for the 96372 issue, which totally doesn't cover the cost, right, of all of the coordination of care and the administrative burden. But it started in your region. It actually started in your MAC, and it was slowly coming across country. And I knew that it was going to happen in Florida, and I was jumping on this. How, for people sitting in your seat when you were running the medical practice and somebody sitting in my seat, how can they be savvy and knowledgeable about the changes happening across the country that they know invariably is going to end up seeping into their state lines? What can people do?
Well, that's a $1 million question. It did happen with us. Noridian was the first one. Noridian is one of the largest managers of our Medicare contractors, of our MACs, and they definitely put that upon our region. There was a tremendous amount of throwing apples and oranges and everything at Noridian as far as we could possibly do collectively together, all the way down to California. We have 13 states actually under the Noridian umbrella. And what we ended up actually, working toward is the solution directly with Noridian, which actually became friendly toward us, because instead of throwing the apples, we started really taking it from a different viewpoint of collaboratively, how can we work this together? And we actually had a great relationship at the end of the day, moving toward value-based contracts to give us a flat fee for our infusions, including everything, rather than besides the buy and bill, but a flat fee rather than actually sticking to their guns of decreasing reimbursement all the way along. And then the insurers followed suit with that in the Northwest. And so we began to be able to negotiate our contracts, taking it off of the Medicare and making our contracts more of a flat fee, moving toward value-based contracts as well.
I always worry about the value-based contract arena, and the term comes up a lot in our world because it puts the burden on the physician. And my concern is, and I really want your perspective, because my concern is, where does the patient fall in this? Isn't the patient responsible for his or her medical care or adherence for the medication? And then when you look at the insurer, what if the insurer denies treatment or delays care for the medication, and then you get into a situation where the patient is hospitalized or has to take on additional care, right? That is so much more expensive than if the initial medication was given at the start. What are your thoughts on value-based care?
Well, my thoughts on value-based care is that it has been proven through oncology that it's a viable option. Unfortunately, with rheumatology, we don't have that urgent, people are going to die scenario. And so the payers will often not want to even negotiate a value-based contract with a rheumatology group, for example, because we're small, we're little, they control every aspect of every move anyway. And so it's a very tough road to try to move rheumatology into it. That's why I'm saying at the end of the day, we're now it's morphing into, rather than value-based contracts, it's morphing into these shenanigans that are happening that we can't even get reimbursed for our biologics that are biosimilars, for example. We're underwater. And how in the world can they expect a community practice to buy the medication and be reimbursed for under what they paid for? This is happening all over with our particular medications itself, with the biosimilar groups. And again, you have one or two options. You send the patients to a high cost hospital because you can no longer buy the drug, or you appeal based off of your data. And that's why I'm saying the new appeal data has to be different than what we've done in the past. What we've done in the past is we try to say the same thing. Patient has tried, failed. We've done everything we possibly can with pre-authorization denials, non-medical switching, and all that. The new one is really about the data itself and being able to look at some of the codification that is happening with the denials that we could actually have in our records and show how diminishing the care is being given to that patient, and then collectively come together with that kind of information to be able to change legislation. But legislation change is a little different than getting paid, right? Like a legislation change, then you take that data and now you pinpoint their exact faults of what they're doing to this patient. You can actually show it by data.
Let's talk a little bit about biosimilars, because I don't think everybody's aware of how this has impeded our ability to provide necessary medications to our patients. So there are a lot of, quote, generic, but we're going to say biosimilars because generic has a different terminology to it, and it doesn't need to have exactly the same efficacy. But biosimilars, there are a lot. We have Remicade, there are 4 biosimilars, 2 that we're, quote, underwater with and we can't buy. I'm experiencing the same situation right now with the biosimilar for Prolia. So can you share with me why medical practices are underwater with biosimilars? Who's at fault?
Well, that's another really good question. It comes down to most rheumatologists want to get paid fairly. In the buy and bill, there's 2 methodologies. One is your pharmacy side of the fence, where a patient goes to the pharmacy and picks up Humira or any of those, right? Those are controlled by a group called pharmacy benefit managers. And pharmacy benefit managers had a huge important role to play back in the day. They adjudicated all of those, right? All of the claims. And so they knew exactly which patient was with what insurance and blah, blah, blah. Unfortunately, what happened back then is that the PBMs used to charge the payers for that service of adjudication. Instead, they decided to take off the payment to the payers and decide to take a percentage of the retail bill of the medication itself. And because of that retail bill, it skyrocketed the cost of our medications, because the higher the bill, the retail bill, not the net from what a doctor gets, but the retail cost of that medication is just astronomical. And so they made more money every single time they increased that cost. The manufacturers contract with the pharmacy benefit managers, because they have all of the payers underneath them. So they have the payers, and so they then contract with them. So is it a manufacturer problem that they're not giving the ASP, the average sales price, correctly to everybody, or whatever? I'm sure most people just want a net plus a profit. We don't get very much profit anyway on our specialty meds. It's not like people are making a ton of money because the profit is so low. It's just that they've now put it as an underwater methodology, and you can't buy these meds, which are hundreds of thousands of dollars a month, and expect to not be reimbursed for it out of your own pocket.
And it's supposed to be average selling price plus 6, but because we have sequestration that nobody ever talks about anymore, it's actually ASP plus 4%. And so underwater means that we're losing money every time that we're buying and billing. So then insurers will turn around and say, well, that's fine. We'll send you the drug. And we're like, oh, now we have to warehouse the drug, right? We have to hold it oftentimes, and then we're tracking down the patient. Oftentimes, if it's a medication that is weight-based, a patient's weight may fluctuate or change, and then we have the wrong medication. Or if the person has an issue with the medication, we're stuck with it because the patient is no longer going on that medication. It's actually costs more money, right? It costs the health industry even more money. Regarding PBMs, is there a need for PBMs anymore?
Yeah, I think that it is an important aspect. I just think that they need to, if literally they need to quit putting these shenanigans where we're literally upside down. And they control that. They control the cost. They control the formulary. They control everything about how a physician can get their hands on their medication. And so they control all of that. And that's really where the problem lies with our medications is, it used to be that those are the things that we fought for. But again, in today's sense, you can't even get your hands on these biosimilars, which are supposed to be cheaper for the patient and everybody. But they literally make it underwater from the get-go. So it's not even after the fact. It's literally from the get-go that you literally cannot use those medications. And so you have to either change the medication, which we all know is also prohibited for the patient's outcome when they're doing well on their medication, or you have to send them out to a hospital, which costs 4 or 5 times more at the end of the day.
And so I would disagree that we actually need PBMs, or if you create a PBM, there's a set amount like $20 or $25 to coordinate the care. The challenge is the 80% of the prescriptions go through 3 PBMs that are all owned by insurance companies. And actually, one of them owns the insurance company. So you have Cigna, you have Aetna, and you have United Health Group that are all involved in this PBM world. I call them the mafia of the insurance company because they're literally just skimming off of everybody. And really the work involved is probably only about $20. So will you walk us through the prior authorization workflow for office administered drugs in a clinic, like eligibility, clinical notes, step therapy, quantity limits, site of care, and where patients and clinics lose the most time and why it delays care for patients?
Well, the pre-authorization, the non-medical switching, the step therapy, these are all new administrative burdens that have been placed onto a physician practice. What physicians don't normally get a very good track on is, when formularies change, and they can change 2 to 3 times a year. Okay, so it's for the same medication that was great in 3 months ago, now is a changed formulary according to the PBMs, who control the cost and the formulary placement. So the formulary placement then is derived from who's giving them the biggest rebates. And so the manufacturers. And so they will place now this drug, either exclude the drug or increase. So a lot of times physicians aren't aware of the change in formulary changes. Even Medicare changes formulary exclusions all the time, and you have to keep up with that. So there's this nuance behind closed doors that really set that motion into just a tremendous amount of delays and appeals. And then you appeal, and then you have to go through the appeal process. And the PBMs are so good at controlling the denials now that most practices just put up their arms and just go, we can't do anything. And then patients who have no idea of the ability to navigate this healthcare mirage of craziness, they're the ones that suffer the most. And so this is going to continue. Like I said, it's just one of those things until we have data that can actually demonstrate that. And we had really good success. We used we used a software program that was called JointMan back in the day, and we were able to track how well the patient's joints were actually doing. And we used that information when we were appealing the process, because that information demonstrated that the patient was actually doing really well when the patient was being denied because the patient said that they were in pain. But the patient's suggestion of pain might be because they gardened too long that day before, right? It wasn't because of their rheumatology joints. And so the two played a really critical role. And that's why I'm saying this effort that I'm trying to build with stories, which are the most amazing part of trying to change legislation, is hearing those heartfelt stories happen. That's what they want to hear. It's, but you couple it with the clinical evidence that you have, and you pretty much have an appeal affirmation because you've clinically put the two together.
So for listeners, what makes a story actionable when they submit our story to our Stories RX? So what is needed, and how can they share one that actually drives change right now?
So I think that's a great question. And one of the things that I try to focus more on is, how has this change in medication, or how has this problem affected their daily life, their work life, their family life, their ability to take care of their children, ability for grandparents to run after their children, grandchildren, their ability to really have a quality of life is one of the main things. And the second thing is the the ability for the physician practice to actually show the coordination of care that you have always done so well, that when it's interrupted, they're actually not able to take care of that patient the way that they were. And so those are the main things. Also mental and anguish and harm for the patient. You can imagine the anxiety that a patient out of nowhere gets a $250,000 bill just because they made her go to this alternative funding plan, and she was not able to get the medication through the patient assistance program, and only through the advocacy of help of a rheumatology advocate was she able to get Aetna to take responsibility, because a lot of times now the insurance companies point their fingers now at the pharmacy benefit manager as the culprit, and the pharmacy benefit manager is pointing it at somebody else. And so no one's taking that responsibility. And until you can get those two pieces together with collectively, will you have this quagmire of being able to run around the healthcare system without as good of results as when you can actually bring that data in front of them with that compelling story.
And what I think is so amazing is that while the PBM points fingers at the insurance company and the insurance company points fingers at another entity, they're all owned by one umbrella, which is shocking to me, but it's breaking it down to explain what is going on in our American healthcare system. Because you said, hey, we're not in oncology, so patients aren't dying. But in the rheumatology world, patients are debilitated. It's activities of daily living.
It's almost more abusive even now, because now we're starting to really understand rheumatology is about inflammation in your body, right? And it can go anywhere in your body. It's not located in one spot at all. And it's just huge amounts of need from the patient population, with few rheumatologists that can actually take care of them left in this world.
Are you only looking for stories from rheumatology patients? What types of stories are you looking for?
No, we had a great rare disease panel that I did one time, and we did a payer luncheon forum around patient stories with rare disease. And from that, it was so sensational that I would love to model it into rheumatology, because it was a real collaboration of payers that sat and listened to these stories, but also collaboratively from then on formed a coalition to work on this. And they are succeeding tremendously in the rare disease space because of it.
That's amazing. So listeners, whether they're clinicians or whether they work in the healthcare space or whether they are patients themselves, how can somebody submit a story to Our Stories RX?
Yeah, you just go on the website itself and follow the little buttons of submitting a story. That's one way. You can also get in touch with us through email, and we'll contact you and we'll do a podcast, sort of like what you're doing, and do your story that way as well. So there's many different ways to make it easy for anybody to submit stories. But like I said, what I would like to do is really form a coalition where those stories can be added immediately from a physician website itself, and that you as a physician practice have those stories in a little library, but also goes up to a coalition that's working on legislative issues collectively together.
And it's ourstoriesrx.com for those who are listening. And I want to point that out. So Karen, I want to wrap this up. You've been in the healthcare world for a really long time. And even in retirement, you're not leaving the arena. If you could create one change within our American healthcare system, what would it be?
That it is so broken that it's very hard to have one change. But, because I've been in rheumatology for so long and because I care for our patients and our vulnerable patients and trying to change legislations, I just think a fair parity of reimbursement needs to be place for everyone, whether you're a community practice or a hospital or whatever. I think there should be a fair reimbursement model that really allows physicians to use the right medication at the right time for the right patient. It's to me, the biggest problem that we have to fix is we just are handcuffed and we just cannot get our hands on the right medication for our patients.
And I really appreciate that, Karen. Thank you. Yeah. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.